So today I'm going to try to make some sense out of the metabolic syndrome. The metabolic syndrome was described by Gerald Reaven, a professor of medicine at Stanford University in the 1980s. What he noticed was that people with high triglycerides and a low HDL, and who also had abdominal obesity, high blood pressure, and a high fasting blood glucose, all had high rates of cardiovascular disease. He also noticed that diabetics had high triglycerides and that they had most of these components that we have spoken about, and that they too had a high rate of cardiovascular disease. He produced journal articles at the time saying that although there was a genetic component to insulin resistance, the most likely cause was the high carbohydrate, low fat diet that was in fashion at the time. Lipophobia was rampant in the 1980s, and his esteemed cardiology colleagues were all recommending a low fat diet. He then went on to do trials, but probably because his career was threatened, he called a low carbohydrate diet a 45% carb diet. We now know that that's not a low carbohydrate diet, and therefore the trials that he did not work. He probably realized that if he pushed an ultra low carbohydrate diet, that his career would be over, much like Yudkin's was in the United Kingdom when he did that. So what is metabolic syndrome? Syndrome X, or a better name for it would be insulin resistance syndrome. Metabolic syndrome is described as abdominal or visceral obesity, arbitrarily defined as a waist circumference of 102 centimeters or 42 inches in a male, and a waist circumference of greater than 89 centimeters or 35 inches in a female. Hypertension, anything above 135/85 was considered hypertension. Raised serum triglycerides greater than 1.7 millimoles per liter or 150 milligrams per dl. A low serum HDL less than 1 millimole per liter or 40 milligrams per dl. A high fasting blood glucose greater than 5.6 millimoles per liter or 100 milligrams dl. If you have 3 or more of these components, you are considered to have metabolic syndrome. When we measure the waist circumference, we are just trying to get an approximation of how much fat there is in the liver and the pancreas. It's not a particularly accurate thing to do, but it's easy to do and gives a fairly good approximation. If you have a look at the US population of adults, and I'm not picking on the US, it's just that they keep brilliant statistics. It's like this all over the world. If there are 240 million US adults, 30% of them, or 72 million, are considered obese with a BMI greater than 30, and of those 30%, 80% of them are metabolically ill. But if you look at the normal weight people, which consists of 70%, 168 million people of normal weight, 40% of that 70% are metabolically ill as well. So in fact, there are more metabolically ill people of normal weight than there are obese people. So the obese people that are metabolically healthy, we call MHO, metabolically healthy obese. And why are they obese? It's genetic, but all their fat is on their hips, none is in the liver and the pancreas. And we call the metabolically ill normal weight people TOFIs. which means thin on the outside and fat on the inside. So the total number of metabolically sick people in the USA is 124 million, which is 52% of the population. Some estimates have gone right up to 88% of the US adults being unhealthy. So although we use waist circumference, really we need to be using ultrasounds of the liver, MRIs and CAT scans of the liver to assess how much fat there is in the liver. Another thing that we can use is liver enzymes, which show us that the liver is inflamed and toxic. So it's becoming more and more obvious that high insulin and insulin resistance is the cause of obesity rather than calories in, calories out. So what does insulin do? The first thing it does is that it enhances lipoprotein lipase to break down triglycerides into glycerol and fatty acids and enhances their uptake by the cells. Insulin is the storage hormone. What insulin also does, it enhances GLUT4 transporter, which takes the glucose and sticks that into the cells. Now you've got glucose, which goes to glycerol. It hooks up with a fatty acid to form triglycerides. Also, hormone-sensitive lipase is inhibited by insulin, so we don't break down the triglycerides and transport them outside of the cell. So as we eat more and more carbohydrates, the energy Krebs cycle is full, so we can't use the glucose to break down into energy. Also, our glycogen stores are full, so the glucose can't go in that direction. So what does it do? It goes along the beta oxidase pathway, de novo lipogenesis, inside the liver. So the liver frantically tries to export as many triglycerides as it can in the form of VLDL, and that's why the blood triglycerides rocket when you eat a high carbohydrate diet, but it really can't cope. So lots of fat forms inside the hepatocytes and you start getting a fatty liver. So not only does this fatty accumulation damage the hepatocytes, but as I discussed in my lecture on diabetes, glucotoxicity and insulin toxicity damages all endothelial cells, including those in the liver. It does this by the production of advanced glycation end products and by reactive oxygen species, which actually damage the cells. You then get clotting. You then get an inflammatory response, which comes in, and these little sinusoids get blocked and damaged, and the liver cells die, and eventually this heals by scarring, and then we call that in the liver cirrhosis of the liver. So as we poison ourselves more and more with an overload of carbohydrates, a non-alcoholic fatty liver forms. About 5% of these will go on to the inflammatory stage, the non-alcoholic steatohepatitis, and about 25% of those will go on to cirrhosis of the liver, which leads to liver failure and death. In diabetics, this process spills over into the pancreas, and you get fatty pancreas, and that is probably why there's a sudden drop-off of insulin when diabetics develop their diabetes. So measuring the waist circumference is just an approximation of this pathology that is going on inside the abdomen. A better way to assess this, the fatty liver, would be various blood tests. We measure ALT and AST in the liver, which is signs of inflammation. The bilirubin, we measure platelets, serum albumin, And then we can go on to ultrasound of the liver and CAT scan and MRI of the liver. The ultimate diagnosis of fatty liver or cirrhosis or NASH is a liver biopsy. There is, however, more to the carbohydrate story than this. So, we used to think that fructose had a saintly status. It's in fruit, it's got a low glycemic index, and it doesn't raise your insulin. But in fact, it is 5 times more potent in causing fatty liver and insulin resistance than is glucose. In the case of glucose, it can be metabolized by all your muscles, by your brain, and by other tissues, but fructose can only be metabolized in the liver. So if the Krebs cycle is full and the glycogen is full, then the only place for the fructose to go is along the beta oxidase pathway, de novo lipogenesis. So the fructose forms fat in the liver, and it is 5 times more potent at forming fatty liver and causing insulin resistance. So in China, they've always eaten a high carbohydrate diet, and you can see that in 1980, the incidence of diabetes was less than 1%. By 1994, 2.5, 2000, 5.5, and now one of the highest percentages in the world at 11.6% of Chinese have diabetes. That represents 110 million people. So what happened? High carbohydrate diet here. What actually happened is they started eating processed food with sugar, with fructose, and gradually their fatty liver and their diabetes developed, as did their obesity, but not at a high rate like the diabetes. So in 1920, the average American had about 10 grams of fructose a day, mainly in the form of fruit. Today, the 12 to 18-year-old Americans eat about 72 grams of fructose alone. If you drink a 360 ml Coca-Cola, there are 40 grams of sugar in that. 20 of those grams are fructose. So many people today attribute the diabesity epidemic to fructose, to sugar that we eat more and more in processed food, because the fructose causes a fatty liver, causes insulin resistance, causes obesity, and it causes diabetes. Let's move on to the next component of metabolic syndrome, which is hypertension. Increased insulin raises blood pressure, and it does this by a number of mechanisms. It causes sodium retention in the kidney. It also stimulates ADH. It constricts blood vessels. It increases heart contractility. Also, the toxic liver excretes uric acid, which inhibits nitrous oxide in the blood. And we know that nitrous oxide is a vasodilator. So in this paper, 174 consecutive hypertensive patients who attended a fasting clinic were put on a water fast for 11 days and then a low glycemic vegetarian diet for 3 months. The average reduction in blood pressure was 37 systolic and 13 diastolic. Of those patients who had severe hypertension, greater than 180 over 110, the reduction was 60 systolic and 17 diastolic. 6.3% of the patients had been on antihypertensives, and all of them were able to stop their medication. This is backed up by the many clinics springing up around the world that are reversing diabetes, and virtually all the people who reverse their diabetes come off all their antihypertensives. So essential hypertension in most cases is insulin resistance and can be reversed. Most doctors will tell you it's essential, we don't know what causes it, here's some medication, take it for the rest of your life. The next thing we'll discuss is high serum triglycerides. High triglycerides have long been associated with cardiovascular disease and other diseases, not LDL, not total cholesterol. There is no evidence that a high LDL or a high total cholesterol is associated with cardiovascular disease. So what happens is you get a glucose overload, you get high insulin, you get de novo lipogenesis. The liver desperately tries to export the triglycerides as VLDL, so the serum triglycerides go up. High carbs and diets and diabetes are associated with high triglycerides. And does the triglyceride cause the cardiovascular disease? No, in fact, it's just a marker. It's a marker of high insulin and high glucose, which is actually causing the endothelial damage by reactive oxygen species and ages, as we discussed before. The same goes for the high ApoB particles, which can be measured in the LDL. They are associated with higher episodes of cardiovascular disease, but they are not causing them. Just like the triglycerides, they are a marker of something else. The fourth component is a low serum HDL, and in fact, high VLDL activates an enzyme which inhibits HDL production. So high triglycerides goes hand in hand with a low HDL. This is a patient of mine with a total cholesterol of 7.2 millimoles per liter and an LDL of 4.2 millimoles per liter. 80% or 90% of doctors would say immediately this patient must go on a statin. But if you have a look at the triglycerides, they're 0.6. Anything up to 1.7 is the normal for the labs. But in fact, it's would be better to be closer to 1. If you have a look at the HDL level, anything above 1 is said to be normal. But in fact, health is probably more in keeping with 1.3 or higher. So what we like to do is look at the HDL to triglyceride ratio, and we like it to be 1 or below. And you can see this patient has got a brilliant ratio. The HDL is very high and the triglycerides are low, and this is perfectly healthy. Do not worry about the 7.2 or the 4.2 figure. The last component of the metabolic syndrome is a high fasting glucose above 5.6 millimoles per liter or 100 milligrams per cent. This takes many years to develop. As you can see in this patient, that the glucose stayed normal for 15 years while the insulin was going higher and higher. And then suddenly there was a decompensation where the insulin was no longer able to keep the glucose down, and it seems as though this patient got diabetes all of a sudden. But in fact, it had taken 15 years to develop. So what happened here? Is that the pancreas, just like other endothelial cells, was damaged by glucose and insulin toxicity, and the beta cells were no longer able to keep producing more and more insulin. Also, there's a damage between the beta and the alpha cells, and the high insulin is no longer able to inhibit glucagon. And glucagon carries on being secreted at a high level. And as you know, glucagon pushes the blood sugar up by causing glycogenolysis and other mechanisms. There's much argument about the exact mechanism of the development of insulin resistance, but the latest research shows that it's probably due to a high carb diet, which forms visceral and liver fat, and the liver then secretes a hormone called retinol binding protein 4. And it's been shown that this retinol binding protein 4 interferes with insulin receptors and causes insulin resistance. The bottom line is that fatty liver and insulin resistance and high insulin levels are intimately related. In this paper, these patients were given a glucose load for a glucose tolerance test, and they were followed up for 11 years. They were non-diabetic patients, and their insulin was measured at 30 minutes, 60 minutes, 90 minutes, and 120 minutes. And what you can see here is if you had a high peak that came down pretty quickly to normal, you only had a 3.2% chance of developing diabetes in 11 years. If the peak didn't come down in pattern 2 here, you can see that at 2 hours the peak was still fairly high. You had a 9.8% chance. Here you had a 15% chance. But you can see in these two, at 120 minutes, the insulin had not started to come down. In fact, it was still going up. And this was highly indicative that you would develop diabetes in the next 11 years. So why do you want to reverse your metabolic syndrome? Well, firstly, it's associated with obesity and diabetes, cardiovascular disease, strokes, many neurological diseases, and in particular Alzheimer's disease, which is just type 3 diabetes and is due to glycosylation of brain tissue, cancer, especially the endodermal cancers, liver disease, PCOS and infertility, endometriosis, erectile dysfunction, renal disease, peripheral vascular disease, retinopathy and blindness. Diabetes is the biggest cause of blindness, inflammation and autoimmune diseases. So what is the conventional treatment of metabolic syndrome? Well, for the obesity, you'll be told to eat less and move more, have a 60% carbohydrate diet, and in fact eat 6 small meals a day to keep your blood sugar even. Well, what are you doing? All you're doing is you're keeping your insulin high and you are promoting obesity. The diet may work for a while, but it will soon reverse. Hypertension. Hypertension is essential, so we don't actually know what causes it. Here, take these drugs and come and see me for the rest of your life and stay on the drugs for the rest of your life. You've got a dyslipidemia. Well, I think we'll have to take statins. Hyperglycemia, we'll give you metformin, and as your diabetes develops, we'll go on to insulin. It's a progressive disease of unknown cause, and we can just manage it. We can't cure it. All of that is complete nonsense. All of these things can be reversed by going on to a low carbohydrate, high fat diet to stop insulin from going high, and doing intermittent fasting to drop your insulin. And these two combined will help you reverse your fatty liver, which is causing your insulin resistance, and to help you become metabolically healthy. I will leave links below this video to other related topics like obesity, diabetes, and intermittent fasting. I hope you've learned something from this, and thanks for listening, and I'll see you next time. Bye.